1990 and 2013, cardiovascular disease increased from 12.3 million people in the world to 17.3 million in 2013. This is a 41% change. But most of this change, a large part of this change, was because the world had more people. There was an increase in population. But the largest part of the change is because of aging, 55%. So once you take these two things into account, you will see that actually we had a 40% age-specific reduction in cardiovascular disease. Now, we set up a study called the PURE study, and we wanted to try to find out why high-income countries, middle-income countries, and low-income countries have different rates of cardiovascular disease. In fact, 18% of cardiovascular disease occurs in low and middle-income countries, and we thought maybe they could have more risk factors. But when we looked at the risk factor burden was highest in the rich countries, lowest in the low-income countries, and intermediate in the middle-income countries, which meant that risk factors could not predict why people had different rates of disease. And here, paradoxically, although the rich countries had the highest risk factors, they had the lowest major cardiovascular disease rate, intermediate in middle-income countries, and much higher in people in the low-income countries. And the answer is here in that in the rich countries, we pick up disease early and intervene, whereas in the poor countries, early disease is not picked up. But once you get disease, people also have a marked difference in mortality rate. So it's a 6-fold higher mortality rate in the low-income countries compared to the rich countries, and 3-fold higher in the middle-income countries. And when you look at total mortality, the same trend. This is because although the risk factors are lower in the poor countries, the treatments are less good, and therefore it's just as important for us to prevent the disease, but also when the disease occurs, to treat it well. Now, many years ago, I made a theoretical calculation that in secondary prevention, if you treated people with no secondary prevention medicines, you'd get an 8% per year event rate. But if you gave aspirin, you would reduce it by 1/4, so 8 will become 6. And if you gave a beta blocker, it will reduce by 25%, so 6 will go to 4.5%. And if you gave lipid lowering, say 1 millimole reduction, it would be reduced by 30%, so 4.5 will go to 3%. And ACE inhibitors would lower it by another 1/4, so it goes down to 2.3%. So if you give all 4, you will see the 8% event rate will go to about 2% event rate, so a 75% risk reduction, which is substantial. Unfortunately, these drugs are not used widely enough. Even in high-income countries, aspirin 5 years after a heart attack is only used in 40% of people. In low-income countries, only 10% in the urban areas and 5% in the rural areas, with the middle-income countries being in between. The same pattern you see for beta blockers, the same pattern for ACE inhibitors, and the same pattern for statins, with middle-income and low-income countries hardly using statins. So if we could improve this, we will have a big impact on cardiovascular disease. So why is this not used? Is it because the doctors in these countries don't know that these drugs work? Well, part of the reason is these drugs are not available. So we published this in The Lancet, which showed that in the high-income countries, these drugs are widely available. In the upper middle-income countries, it is 78% availability in the urban areas and only 60% availability in the rural areas. This is lower in the low middle-income countries and much lower in low-income countries, excluding India, where 36% of urban areas have the drugs, but nobody in the rural areas had the drugs available in the pharmacies. Now, India has quite a big pharmaceutical industry, and there the availability was high. But if you look at the cost of the drugs, you will see that the cost of the drugs are very low as a proportion of people's income in rich countries. It's under 1%. And in upper middle income countries, in the urban areas, you will see it's about 3 to 5%. In rural areas, it's 10% of people's income. Same thing in low middle income countries. But in low income countries, you will see it's about 15 to 20% of the monthly income in the urban areas and nearly 50% in the rural areas. And in India, although these drugs are widely available, you can see affordability is low. And when you look at the proportion of people who cannot afford these drugs, you will see in the rich countries, practically everybody can afford the drugs. But as people are in poorer societies, for instance, in low-income countries, excluding India, or low-income countries, including India, you will see only 40% of the urban people and 70% of the rural people cannot afford these drugs. And when you look at the rates of availability and the rates of use, you will see if the drugs are not available, the use goes down 90%. And if it is available but not affordable, it is going down 80%. So until we solve the issue of availability and affordability of drugs, we cannot improve secondary prevention worldwide. The same thing is true for hypertension control. You will see the prevalence of hypertension is more or less the same and slightly lower in low-income countries. But awareness is of only 50% in high-income countries, upper middle-income countries, and lower in the low-middle-income countries and low-income countries. Once somebody is aware in high-income countries, practically everybody is treated. In the low-income countries, only 3/4 are treated. But the rates of control is very low. In rich countries, only 20% have control, and in poor countries, only 10 to 13%. This again is because people don't use combination therapy. Now, the third thing in addition to this, is to think about smoking. And you will see that smoking increases the rates of cardiovascular disease substantially, so that even light smoking, smoking 10 cigarettes a day increases the risk threefold, and in smoking 20 cigarettes a day increases the risk sixfold for coronary heart disease and fourfold for strokes. So smoking is a major problem. Now in the UK, since 1960 to 2010, premature cardiovascular disease between 35 and 70 decreased from 42% down to 19%. That is more than a 60% reduction in risk. But most of this reduction occurred because of the decline in smoking. So deaths among smokers went from 20% down to 4%. Whereas in the non-smokers, you will see this is about 23% and this is about 15%. So that although there is a decline in non-smokers, it is nowhere as nearly as large as the smokers who stop smoking. Now, tobacco is still a big epidemic. Now, in Western Europe and North America, cigarette sales are decreasing. In China, cigarette sales are rising, especially in males. And in 1990, 10% of men died from smoking. In 2010, 20% will die from smoking. And in 2030, 30% will die from smoking. And this shows the annual production of cigarettes in China. It's going up. And the biggest manufacturer of cigarettes in the world is the Chinese government. So their government in China kills its own people. Now, in a very good paper in The Lancet, Richard Peter and his group said smoking will cause 20% of all deaths in China in the 2010. But this will increase, as I told you, so that if there is no change, in 2010, 1 million men will die from smoking every year. 2030, 2 million deaths will die, and by 2050, 3 million will die, unless there is widespread cessation. Now, annual sales in the world, China and India will be the countries using the most amount of tobacco a year, and of the 6 million deaths that occur every year, 2 million deaths will be from India and China, and by the middle of this century, 10 million will die. Now, in the last century, 100 million people died from tobacco. In this century, 1 billion people will die from tobacco, of which 100 million will die by 2020, 250 million will die between 2020 and 2050, and 500 million will die between 2050 and 2099. Now, most of these people here are alive and are our current smokers. So if we have to save these deaths, we have to get people to quit. Most of these people are not yet born, and in them, stopping them from starting to smoke, preventing smoking, becomes important. So the biggest impact in preventing deaths from tobacco in the next 25 years will be in taking current smokers and getting them to quit. But preventing children's smoking will have an effect after 2050, and before 2050, it is quitting that will stop smoking. Now, the UN has made a target of 1/3 less smoking by 2030, and governments worry whether their taxes and their returns will, and their revenues will decrease. Right now, governments receive $300 billion a year in taxes. But if the real price of tobacco remains the same, when smoking reduces by 1/3, governments will lose $100 billion a year. But if real prices double and smoking decreases by 1/3, governments will gain $100 billion. So the main and effective way of controlling tobacco is to double the price of tobacco. There are really only 5 things that we need to deal with to improve, to substantially reduce cardiovascular disease: tobacco, blood pressure. You saw earlier on Dr. Il-Soo showing data from Korea saying what a marked decline you've had, a 37% reduction in cardiovascular disease, largely due to reductions in blood pressure, reducing blood lipids, reducing adiposity, and improving secondary prevention. Now we know that if you reduce blood pressure in hypertensives by 10 millimeters mercury, systolic, we will reduce risk by 1/4. Now, lipids are also very important, and if we can take a low dose of a generic statin and reduce LDL by 1 millimole, we'll reduce vascular risk by 20%, and there are very few side effects. And obesity, a 5-unit difference in BMI, will reduce MI and strokes by 1/4, especially in high-income countries. In Korea, you're lucky, you still have not had the epidemic of obesity, and please keep it that way. So, some countries like Mexico have an unusual problem, and these are data from a paper that is in press in the New England Journal. In Mexico, there are more diabetics than in the US, but the mortality in a diabetic is 2.5 times higher in Mexico than in the US. And the relative risk of those with diabetes is usually 2 around the world, but in Mexico it is 4, and this is largely because diabetics are not treated, their glucose is not controlled, and they're not on blood pressure lowering or lipid lowering. So this is a key part of controlling cardiovascular disease globally. Now, in the World Heart Federation, it works with the WHO in trying to reduce cardiovascular disease globally. And we did an analysis from the Pew study where we said, what proportion of people had cardiovascular disease at baseline? 5%. But 19% of the events in the next 5 years came from this 5%. In those with hypertension, 40% had hypertension, but 66% of the events came from this group. Smokers, 20% were smokers, but 30% of the events came from this group. So if you take all these 3, and there is some overlap, 55% of the people represent these 3 groups, and 81% of the future cardiovascular disease comes from this group. You can add diabetes, and that goes up to 10% has diabetes, and 26% of the events occur. But there is a lot of overlap in these 3 groups. That's why when you add diabetes, 55% only becomes 58%, and 81% goes up to 84%. So if you target these 3 or 4 groups, you can avoid most of the deaths from cardiovascular disease in the world. The goal of reducing cardiovascular disease by 25% by 2025 is the WHO's goal, and the WHF, the World Heart Federation, is a partner. In fact, I believe we can halve it, we can do better. And we are propagating 3 evidence-based, feasible, and low-cost priorities: tobacco control, improved hypertension control, and improved secondary prevention. And we created 3 roadmaps. The roadmaps are not guidelines, they go beyond the guidelines. They are implementation strategies. And what this is to identify what policies are needed so that governments will invest, what strategies are needed at a governmental and a societal level, what are the barriers to implementation and how to overcome them, and how do we integrate policy, health systems, and clinical approaches to have the maximum impact. I would urge you to read these roadmaps, and I'll show you where they're published. So these are now being developed globally. They've had meetings in every continent of the world. In Asia, we've had meetings in China and in India, who are partners of the World Health Federation. And I would urge the Korean Society to become a partner, along with Japan is already a partner, China is a partner, India, Saudi Arabia, the UK, Canada, US, and Brazil. And we then take these roadmaps, work with our partners to customize it by each country, and then we roll it out. Then we monitor the progress on how the roadmaps are implemented. We revise the roadmaps after identifying the things that work and the things that don't, and we create a global knowledge bank of expertise and experiences. These roadmaps were published last year in Global Heart. The first one is on secondary prevention. The second one is on simplified methods of blood pressure control. And the third one is in tobacco control. The next thing that the World Health Federation does is to improve capacity for knowledge translation, to implement the knowledge that we have. So we have a program called the Emerging Leaders Program. The first one was kicked off in Canada in 2014. The second one was in Peru in 2015. The third was in India this year. And the next 2 rounds will be in Africa in 2017 and the other one in 2018. And usually people from the region come there. So please do come to the ones in China. And we invite you to send mid-career level people, not senior people, not junior people, but mid-career people. And so far we have trained 35 emerging leaders. It's a 1-year online course followed by 1 week of in-class, face-to-face discussions. And then they develop programs and projects that they carry out collaboratively over 3 years. It's described in 2 articles in the Journal of the American College of Cardiology and in Global Heart, and it is our intention to continue this for the next decade or more and train between 150 and 200 people from 100 countries so that they can become leaders in their own country in changing cardiovascular prevention. And these are the 2 articles. This is the article that was published in Global Heart, and this is the article that was published in JACC. The second capacity building program is improving prevention in primary care. Primary care is where most of the patients are seen with hypertension or diabetes or long-term secondary prevention. And this is based on a course that was developed in India, and the course is now being developed, and it will be ready in December 2016, and it will be rolled out. And then other countries, especially our partners, can take our course, modify it, and implement it in their country. The other thing we're trying to do is improve access for essential medicines for cardiovascular disease prevention. And the poly pill is something that we are very keen on, and we are trying, along with the WHO, we made an application to get it on the essential medicines list. It will lead to health dividends by improving access, patient and physician compliance will improve, and health impact will be greater. It will lead to lower costs for the same prevention, because by packaging drugs into 1 pill, you will reduce the cost of distribution and packaging. And we are now working to identify the barriers to overcome regulatory, business, and attitudinal aspects. And initially, our applications for secondary prevention, but this has a role in high-risk primary prevention, like hypertensives or diabetes. And our working group involves academics, cardiologists, epidemiologists, economists, government policymakers, healthcare payers, and providers, and this group is very active. Now, these are data between 1970 and 2010 by country income range of those dying at different age groups. This bottom here is 0 to 49. This red one is 0 to 49. This is 5 to 49, and this is overall. You'll see in the world mortality has decreased. You'll see that this pattern has been in low-income countries, in middle-income countries, upper middle-income countries, and in high-income countries. And throughout the world, mortality is decreasing. Now, if we take where we are today and look at people between the ages of 50 to 69 and 0 to 49, 21.3 million deaths occur in the world today. And if nothing changes, by the year 2030, 44 million deaths will occur, half below the age of 50, half over the age of 50. But if the current rates of fall in mortality continues, we will see, instead of 21 million, we will see 13 million, and instead of 22 million, we will see 17 million deaths. So instead of 44 million, we will have about 30 million. That is a 33% reduction in deaths. But with improved efforts at prevention, this should accelerate, and we should get, instead of 21 million, we should get 11 million, and instead of 23 million, 15 million, which means only 26 million deaths instead of 44 million deaths, or a 42% risk reduction, or 42% risk reduction in mortality. But we can halve death rates, as I've shown you from the various intervention, in which case instead of 44 million, we will only have 22 million, or 50% reduction in mortality, age-specific, globally. This is a huge potential. Imagine saving 22 million lives by the year 2030. This is possible. Now, the World Heart Federation has published its vision for worldwide cardiovascular disease prevention in the March issue in 2015 in the Lancet, led by me, involving David Woods, the next president, and Srinath Reddy, the last president. And we came up with 8 strategies. The first one is to build partnerships across health disciplines, medical and non-medical groups, and governments for the control of non-communicable diseases. Second is we need good health information systems. You're probably fortunate in Korea in having that, but most of the developing countries in Asia do not have good health information systems. We should enforce tobacco controls, hypertension control, and secondary prevention. And we need to look at an integrated community care, and that could be best done not by physicians, because there aren't enough physicians, but by non-physician health workers, especially for hypertension detection and control and secondary prevention. And this is something that can be done worldwide. We should improve access and affordability of low-cost proven drugs and of healthy foods. Incidentally, fruits and vegetables are very expensive compared to the unhealthy foods, and we need to improve that. We've just published a paper in Lancet Global Health showing that actually fruits and vegetables are really quite expensive. We need to develop knowledge translation and implementation, and that's the programs that we have at the World Heart Federation. Since cardiovascular disease is a disease that affects the whole of society, and 1/3 of people will die from it, we need to get the entire civil society involved. How was polio and smallpox conquered? It was conquered not just by physicians, it was conquered by the whole of society playing a role. And we need partnerships between high and low resource countries. A rich country like Korea can partner with a poor country in Asia and help them do better. Perhaps you can help Laos, Cambodia, or one of these countries to get better and have better cardiovascular disease control. And we need to do studies that are not just national, but we need to do studies that are international, so that we can look at the variations in diet, the variations in activity, alcohol consumption, and tobacco, and how they affect cardiovascular disease. So I believe that we will be able to reduce cardiovascular disease by 50% within one generation. And it requires all of us working together globally to achieve it. Thank you very much.